I'm really honored, and it's really quite a pleasure to speak with you today. I think my talk's going to be a bit different than your last couple of talks, but hopefully through all of this you can glean information and try to put it all together. And if I say something that seems different than other people have said, just stop me, because I think that happens a lot in oncology, and I'm sure you all know that, is we all think we're saying the same thing and you're hearing very different things. So please interrupt me along the way, and we'll hopefully have this be educational for you. So I was asked to talk about novel therapies for high-risk neuroblastoma. And in my mind, you know, it's kind of a continuum, and a lot of times people think, well, she's just going to talk about what are the treatments for relapse. And I thought it would be good to talk to you all about what are the current therapies for high-risk neuroblastoma, how do they differ across the world, and how are we thinking about bringing new therapies in for newly diagnosed patients? See, I have a typo, sorry. And then what are some of the challenges of doing these clinical trials? And then talk about what early phase clinical trials are being done both in Europe and in North America. I think you are all very aware of this, but neuroblastoma is not a simple feat. It is a very heterogeneous disease, and even high-risk neuroblastoma is a very heterogeneous disease. So to say that we know exactly how to treat neuroblastoma would be an overstatement beyond belief. But we do know that we can look at a child when they're diagnosed, and we can think of clinical factors about that child, and we can also look at their tumor and look at certain biologic factors of that tumor. And just that can help us predict how that patient is going to do and use those factors to assign treatment. And as John mentioned this morning, you know, this really is kind of what we're talking about, precision medicine. It may not be as sexy as you think of doing a whole genome sequencing, but we are gathering a lot of information on patients' tumor and using what we know to the best of our ability to try to cohort patients. And our hope is that we'll get better at that and that we'll be able to better assign patients to treatment over time, and we'll talk about that. But you know, what we're talking about today is this group of high-risk neuroblastoma. You've seen a lot of Kaplan-Meier curves, so just to remind everyone, usually here is the probability of either surviving or of having an event. And when we talk about event, we're generally talking about having the neuroblastoma come back, or less likely, but can happen, actually dying from toxicity of therapy. And you'll see here that this big drop-off over here, this is because this is a recently updated curve where we took patients only just treated from 2006 going forward. So there's very few patients out here, and every part of this curve is a proportion, okay? So how many patients are surviving compared to the denominator of how many patients actually got out to that far from their diagnosis. So all it takes here, if you just have a few patients, is this drops very quickly. So as Holger was talking about, this is not very stable, but I think we all get the point that there are patients who do not do as well and who we need to put together and devise treatment for those patients. So what is treatment for high-risk neuroblastoma? It has really taken 20 years of randomized clinical trials performed in Europe and in North America to come up with what internationally we all agree is the standard treatment for high-risk neuroblastoma. Lots of chemotherapy up front with surgery, followed by very intensive chemotherapy that requires stem cell support, radiation therapy, and then finally, as Holger was talking about, treatment of what we call minimal residual disease. These are patients who we think they're in remission, but if we were to just stop treatment, the vast majority of the patient's tumor would grow back, and so we know there's neuroblastoma hiding there, and we need to come up with ways where we can treat that, because whatever's hiding there at this point is pretty resistant to all the stuff that it has already seen. So where do we go? Oh, what are the problems with this? Well, the problems with this are that about 20% of the patients have what we call refractory neuroblastoma. Someone asked that question earlier today. Their neuroblastoma just doesn't respond the way we would want it to. Furthermore, those first 6 months, 9 months of treatment are toxic, and unfortunately, we do have children who die of that toxicity. So that needs to really be considered. And then finally, even for children who get all the way through this, there is a probably 25 to 35% chance that those children are still going to have their neuroblastoma come back. So we realize that we have a long way to go and need to work hard to get this better. So what are we doing for treatment? This is the paradigm that we're using in North America, where patients get induction therapy, stated here. They have their stem cells harvested early after 2 cycles of chemotherapy. And then they go on for transplant. And then, as Holger said, they go on to receive immunotherapy, plus retinoic acid. And what we've really focused on for the last 2 large randomized clinical trials in North America is how do we make this first part better? How do we get more kids to respond, and how do we maximize that response so less kids are recurring overall? So the most recent clinical trial that we presented here, and I recently presented at the ASCO meeting, we looked at an induction regimen that incorporated topotecan, relatively new drug on the block, and had not been used until the early 2000s for treatment of neuroblastoma. And then in those children who had had a sufficient response to induction chemotherapy, we randomized them to what we at the time considered our standard transplant in North America, so these 3 drugs, to 2 transplants. First, a transplant with cyclophosphamide and thiotepa, and then 6 to 8 weeks later, patients received a second transplant with carboplatin, etoposide, and melphalan. And then all patients got radiation therapy, and then all of the children were eligible to go on to the immunotherapy trials. And what we have found with this trial, now with a median survival of 4.5 years from the time of randomization, the event-free survival, so the risk of having your cancer come back, was less if the children received tandem transplant versus single transplant. Now, I will tell you, that was, while I was very happy to see that we had improved the outcome, none of us in the neuroblastoma community wanted this trial to specifically be successful in a way of, I say that not to make you think I'm weird, but this is a huge amount of therapy, and we really wanted to say, maybe we don't have to intensify therapy anymore. This is such toxic therapy for kids. You know, do we really need to do this? But we felt it was really important to do this study because we had to know that, and we had to know which way to move forward. And so now we know that neuroblastoma, sure enough, really does respond to intensive therapy. And by intensifying that block of consolidation, we are further improving the event-free survival. Now you will see that these curves look the same. This is the overall survival, but this gets into the statistics of these clinical trials. You cannot it's too early to look at overall survival for these children, because if you have an event, meaning your neuroblastoma recurred, you go on to get more treatment. John talked about the patient who was on their 6th clinical trial. It would take years to say to everyone, nobody get any more treatment, we just want to see how you survive. That's not realistic. And so what we use is event-free survival because we know ultimately that does predict for overall survival, and that allows us to do as short as possible a clinical trial so that we can get the answer we need and we can move forward. And what was also important in this trial is that 75% of the patients who were randomized did go on to get immunotherapy. So anytime we have a new trial, we always have these trials leapfrogging, and so we have to make sure we're like comparing apples to apples. We didn't want to have, maybe the Tandem kids did better because more of those kids got immunotherapy, but thankfully, both arms got the same amount of immunotherapy. 75% of kids on both arms got immunotherapy. And if we got to immunotherapy, we still saw that the kids who had tandem transplant did better. And in fact, because we're kind of further out in treatment, we're actually already starting to see that separation of the survival curve. So we have seen that impact even in what we consider current day treatment. Yes?
That's 2 transplants.
The blue is the 2 transplants. Single transplant, yeah. So the children who were randomized to receive 2 transplants had less of a risk of having their neuroblastoma come back. Does that make sense? And this is never a number I could tell a patient or a family at diagnosis, 74%, because these are the children who got through everything and got immunotherapy. So you have to also remember these numbers when people start throwing numbers out there that seem like, oh my goodness, that is so great. It's really a select group of patients that we're talking about. But it was important for us to look at this because, again, we want to always make sure that we're looking at patients who actually got what we think is the best possible therapy.
Yeah. And that depended, that we've got randomized, but that depended on how well and the initial part of how they responded to the initial treatment.
Exactly.
And if they didn't, then it was better for them to get the double transplant than
So patients enabled to get the randomization right here. Whoops. No, that's quite all right. This is perfect. This is what I want to do. You couldn't be randomized if your disease got worse during the induction, okay? So you had to have already had a response to get randomized. So we already have a select population. And then you got randomized. And this is just all comers who got randomized, whether you got a tandem transplant or a single transplant. And then if you got through all of that, your disease didn't get worse, you didn't have bad toxicity, you went on to immunotherapy. Initially, when this trial first started, we were actually still doing the randomization of immunotherapy versus no immunotherapy. So that's why there are some patients who didn't get immunotherapy. Does that make sense? So kind of overlapping with this study, our European colleagues were asking a very kind of similar in content question of what is the best consolidation regimen. And so they, in their hands, felt that busulfan and melphalan might be better and less toxic than the regimen that we were using in the United States, which is the SEM. So don't try to compare the numbers because really you're comparing apples and oranges there because it's a different patient population. It was a lot different. But the bottom line is that they found in their hands, with all the treatment that they deliver in Europe, that busulfan melphalan was the superior regimen. So that does leave us in, and I have a lot of families say, well, now what do I do? Are you going to give me busulfan melphalan? Are you going to give me tandem transplant? And I say to them that in the United States, with all the treatment we do, what we know right now is that's tandem transplant is what I would recommend. Whoops, did I not? Oh, I'm going to get to what we're going to do. But we are also trying to, and as I'll show you, tease out that can Bu-Mel be as good as tandem, and would that be okay? If it's less toxic, we would love to be able to use that instead. And I'll show you how we're hopefully going to try to address that in the clinical trial in North America. So as I talked about, though, we're very encouraged by those results. We're going to move forward with standard treatment of tandem in North America, but we're still missing a bunch of kids. We're not doing a good enough job with induction. So how do we address that? Well, John started talking to you about, are there ways that we can start to predict which therapies are going to be ineffective for patients, assign them right away at the beginning? And there is a ton of work going on, but we are really not there yet. Our factors that we know about, NMIC amplification, age, stage, all of those things are the best that we can do right now and have not been able to validate anything differently. So then maybe what we can do is let's think about how we can incorporate new agents into the treatment up front. And so there's different ways to think about this. And again, we're talking about, the term that everyone likes to use, precision medicine. We're trying to say, how can we direct the therapy at cancer cells a little bit better than we're doing with the sledgehammer of just a lot of chemotherapy? And there's 2 different ways I like to think about it in my head. One is kind of phenotypically, what's different about neuroblastoma than normal tissues, and how can we maybe target that? And that may be in most of the patients. It doesn't have to be in a tiny, small cohort. So some of the things that we can think about is using MIBG with radioactivity to deliver treatment to kids with neuroblastoma. And immunotherapy is that kind of phenotypic targeting. Neuroblastoma cells express the GD2, and the immunotherapy goes after that. So can we think about ways to incorporate that into treatment? Alternatively, you can go after these molecular targets. We were talking with John earlier. Someone asked the question about why aren't we doing whole genome sequencing? And John made the point that, more than half of the time, maybe even 2/3 of the time, we actually don't have a true target, even with that whole genome sequencing in patients with neuroblastoma. We do know of a target, and Mick, and I'll talk about what we're trying to do, but that turns out to be pretty hard to actually target because your normal cells in your body rely on those kind of molecular mechanisms to survive. And then the ALK is definitely a target, but unfortunately it's only in about 10% of patients with high-risk neuroblastoma. So it's a little bit tricky on how we would really incorporate those molecular targets just yet. So let me just spend a few minutes talking about MIBG. We know that 90% of patients with neuroblastoma will actually take up MIBG. It has to do with the neuroendocrine stem cell cell origin of neuroblastoma. And what you're all familiar with it is because we use it as a diagnostic tool. So this is a patient, unfortunately, very similar to many patients at diagnosis, who we give I-123 MIBG to. It gets taken up by tumor cells, and then we can take a picture of it. So this is the bone metastases, and this is the primary tumor in this patient. Well, we also know that we can utilize radioisotopes and put more of the radiation onto the MIBG, and this is a good visualization of saying, can we better direct the radiotherapy to all of these spots? Because we could never have given traditional external beam radiotherapy to all of these spots. It would be too toxic for this child. There have been a lot of studies. Kate Mathey in North America has been a huge pioneer in this area. Mark Gaze in England also has done a lot of work in this area. And in patients with recurrent disease, we see anywhere from a 25% to 40% response rate in many clinical trials. Probably the best response rate of anything that we use right now for recurrent disease. And we also know that if you look at places where patients recur after initial treatment, many times it's in the same bone that they had the disease in initially. And so we do think there's minimal residual disease in those sites. So again, there's potential that the MIBG could be taken up in those sites and be effective. So what we are proposing and hoping to open within the next year in North America would be to study in a randomized fashion whether the addition of MIBG to children with high-risk neuroblastoma will improve their outcome. This is not an easy treatment. I don't know how familiar you are as families, or if any of you have had children who have received I-131 MIBG. It's actually pretty well tolerated, but in order to give it safely to the providers that are giving it and to you as families, the children have to be in a lead-lined room separate from other children and be in that room for 3 to 5 days. The room has to be covered with all kinds of paper so that their radioactivity from their body and from their sweat and saliva doesn't contaminate the room for future patients. Families are very nervous when we have to do this. It always, I think, turns out better than any of us fear it will be, because I think most kids think, this is great, I'm finally in the hospital and no one is bugging me. I get to watch TV all day, I get to eat whatever I want, I ring a bell, people come in. I am always amazed at even the patients who are most anxious about being around providers. Thankfully, generally do well with it. But it's one more stressful thing, and I think it's really important for us to say, is it really improving the outcome or not? And the only way we can do that is a randomized trial.
They're doing the MIBG to kids that have relapsed now.
Yes, we are doing this for recurrent patients, and we have trials. And then we have done a few pilot trials in North America just to make sure it's really feasible. Like, think about this. Now, not every hospital can do this. It's highly specialized. So you have you're just been told your child has high-risk neuroblastoma, and now you have to start thinking about in 6 weeks and 12 weeks, I'm going to have to take my family somewhere else to meet new doctors, to get this MIBG. So we had to do these pilots to just make sure we could actually arrange this and that patients, insurance companies would approve the patients to come. So we've done that, and we've hopefully worked out the logistics of having that run as smoothly as possible. And now we will randomize children after 2 cycles of, 1 cycle of chemotherapy to either receive what we say is our standard treatment now, our chemotherapy plus Tandem transplant, and then antibody therapy, or to receive MIBG during induction therapy. Now, this is going to be for newly diagnosed, yes, within a year. We're hoping to open. And now I remember I told you that in Europe, we had shown, our investigators had shown that Bumel was better than some. So this is our way of trying to make this comparison. So we are going to have an arm where our patients get MIBG plus Bumel. And we can ask statistically, is Bumel inferior to the Tandem? It's not as strong of a relationship as doing a true another randomized trial, but we feel that this is an adaptive way to utilize less patients, get the study done as quickly as possible, and hopefully bring all this information from around the world together to have the best treatment for patients with neuroblastoma. And likewise, our European colleagues are also going to be doing a similar study. The difference is that they are going to only have patients who do not respond to induction. So they'll get all the way through induction, and those 25% of patients who have a poor response will get some more chemotherapy, and then they will be randomized to either receive MIBG topotecan followed by busulfan, or more of a Tandem transplant, so Thiotepa, and then followed by busulfan. So together, I think that we will all kind of come with different ideas about how to best incorporate MIBG into the treatment for high-risk neuroblastoma. Okay, so moving forward, I'm probably going to blow through this a little bit because Holger just spent so much time talking about immunotherapy, but I'd like to talk about a few important features of this. So as I said, now we're done with the induction and consolidation, and we have what we call the treatment of minimal residual disease. And it was really the study done in the 1990s where nobody thought of doing this before, that we said, okay, well, treatment's done for half of the patients, but the other half of the patients would get isotretinoin, which had been shown to cause neuroblastoma cells to stop growing and what we call differentiate, try to become more normal and die off. And it was an oral medicine. It was really a, kind of seems silly now, but it was like really a paradigm shift of we're not going to give more chemotherapy, we're going to give an agent that works completely differently to these children, and in a randomized fashion showed that it improved the outcome for patients. And then, as you all know, we then took a second randomization and said, okay, now here's our standard, retinoic acid, but we're going to add immunotherapy. And in this trial that ran from 2000 to 2009, took a long time to get that many patients on the trial, we did show that the addition of immunotherapy improved the outcome. But as I said, we still have about a third of the patients, maybe a quarter of the patients now with Tandem transplant, whose neuroblastoma still comes back. So we're very excited. We think there's a role for immunotherapy, but we have to get smarter about how are we going to make this therapy better. So what can we do? Holger just talked about, is it necessary to utilize cytokines? The IL-2 that we use is definitely adds to the toxicity, but it's not just there because we just picked it out of the hat. It actually kind of biologically has a role in enhancing the immune system, and so people are still nervous about what is the best cytokine, and probably especially after transplant, kids' immune system is kind of shot, so we want to be able to give some of these cytokines to enhance that. maybe, as Holger was talking about, giving it in a different way can minimize the toxicity and maybe even make it better. And then there are all different kinds of anti-GD2 antibodies that people are trying to look at to see if we can improve the outcome for that. So Holger showed this. Our European colleagues have tried to look at whether adding IL-2 improves the outcome, and in their preliminary analysis, they do not see any difference in it. I think it's really important, though, and someone brought it up, 25% of the patients could not get IL-2 and stopped immunotherapy. And so it does make us a little worried that we're not still quite sure whether the addition of IL-2 is necessary or not. And I actually say that this trial was somewhat of a victim of the success of the North American trial. Our trial went on for so long that we got really good at managing the IL-2 side effects. You know, I've been treating patients with this since 2000. I know exactly what I can do, and my nurses know what they have to do to kind of get a patient through it. And this trial enrolled so quickly at a lot of centers that you see this IL-2 toxicity and you say, what are we doing? Enough is enough. And so I think that their idea actually of randomizing the continuous infusion with or without IL-2 is excellent to just really answer the question. And I think in this study, they will know, they have more experience with the IL-2. Centers now have the ability to have the appropriate supportive care. And I think if this study shows no benefit of IL-2, then I think we will all feel very, very comfortable that we do not have to use IL-2. Yep.
The IL-2, it only affected, we had the IL-2, it only affected our child while she was on it.
Yes.
When it was stopped,
Yes.
it was gone.
Right. But unfortunately, no, there isn't. And I think, you know, that's what I tell families a lot when we get to the immunotherapy phase. I say, this is a really hard phase, but it's really different than everything else, because in your mind, you're thinking chemotherapy, feel yucky for those 5 days, and then next week I have to worry about the infection. Whereas immunotherapy, it's like so intense for those 5 days, and then maybe a couple of days of kind of getting over that, and then mostly kids feel fine. It was horrific, though. Yeah.
Why is it ran over 10 hours instead of 20? I know with my son, they did it over 20 and it was night and day.
So it's a good question. Some patients can get it over 10 hours, and then therefore they're less exposed to the pain for 10 hours, being on narcotics. But some patients require all 20 hours. Now, the North American version of the antibody, there's further testing that's going on to get stability testing to try to even see if we could do this 10-day infusion like they're doing in Europe. So the drug company is working on that to see if we could even do long-term infusion in North America. But right now, 20 hours is the limit. You know, it's just not, every patient doesn't feel that way. Some families feel that even the long infusion, the kids are barfy, they just don't feel well. So I have some families who say, I want it over with, next time can we make it shorter? So I think it's it's metabolized probably differently in some children. I think older kids have different side effect profile than the younger kids. I think it's not quite that simple.
The machine malfunction on my son, and it was set at 20 hours instead of 10 or 20. It was done in under an hour. He screamed, and then it was done. So I'm not sure, we were like all of a sudden 10 doctors and the thing, they're all like, all our faces on like, what the hell just happened? But
someone else have another question?
The thing that is mentioned a lot is that you send kids home with a pump, and not every parent is going to be
exactly.
Having a kid with a pump.
And also in North America, not all insurance companies will pay for the home pump. So some kids in North America have to even be admitted for that week of low-dose IL-2. So it's so complicated. I mean, there's a lot of factors we're talking about here that, but I think that, trying to minimize the side effects of immunotherapy while making it as effective as possible is certainly the intent of ours. The other thing I want to I'm going to digress a little bit, but I want to talk about, so we've just talked about this minimal residual disease, and we've talked about immunotherapy. And there's a lot of angst on everyone's part when therapy ends. Like, shouldn't we be doing something else? I mean, when we were just doing cis-retinoic acid, I would have families ask me, can't I just do this more? Like, people take this for acne. Can't I just keep on this drug? And so there have been a couple of trials, and I don't even have the vaccine trial up here, but that are opened and are in a non-randomized fashion where patients are receiving these agents with the hypothesis that they may prevent recurrence. But I'm going to talk to you a little bit about the DFMO trial just because I feel it's really important that we all understand what happens when you take those kind of trials and you try to compare the results and you try to say that you know what you're doing. And so let's just talk about that a little. And again, I'm not trying to be unprofessional. This is educational, so I want to just go through this. So here's the curve that I told you about for high-risk neuroblastoma. So, you start at the beginning and everyone is alive. Everyone is surviving and no one has recurred because you're just at the beginning. And this is a matter of years after. So you can see kind of the slope of the curve, how steep it is the rate of patients recurring from high-risk neuroblastoma. So here's your end of treatment, 15 months of treatment for high-risk neuroblastoma. And you can see right here, 2/3 of the treatment failures actually happen while we're giving the treatment. So that's sobering in and of itself. Now, if you then, look at that time right after the end of treatment, and you say, okay, what happens during that period of time, those 6 months after the end of treatment, of the kids, the rest of the kids who are going to recur from high-risk neuroblastoma, half of them do it in that 6 months. So we're still in that very steep curve. So if you look at the curve and you look at 1 year after treatment, you can go back to our old curves from 0032, and you can say best case scenario, at 1 year after completing treatment, 98% of the children are alive, and 84%, because they've had to get all the way to the end of treatment, 84% will have not had a recurrence. So here's what I'm talking about, though. I'm talking about you had to get to the end of treatment without your recurrence. So I'm already removing this big blue box, and you had to get here. So those are the numbers from COG. And if you go to 2 years, they drop a little bit, 92% and 76%. So that's just kind of using the math of that curve and if you got to that point. So the DFMO trial took children who were not only at the end of immunotherapy, but they could have been as much as 4 months out. So in that pink box, they could be anywhere within that pink box. So here's the pink box. So these children, anyone in here, could have enrolled on the DFMO trial, but you could not have already had your recurrence. So that's a really important thing to consider. So here's your eligibility.
Sorry, is this DFMO as a single agent?
Yes, yes. So this is what happens when you don't do a randomized trial and you try to look at a select patient population and you try to make heads or tails of what the results mean. So I'm going to give you the results of that trial were presented here. There's been publicity. Several people, my parents have sent me web-based things that came out this week. The event-free survival is 92%. Okay? I just told you that our event-free survival is much less than that, right? COG data says that it's 84%. We're going to use the 1 year mark because all of their patients, the median time is not out to 2 years. So actually you shouldn't really be talking about 2 year event-free survival if all of your children on the study aren't out that far. Okay, so here are the patients who have enrolled on the COG study with the antibody. All right, and remember I told you that 50% of the remaining relapses are going to happen during this period of time. So you have this patient population that you say you didn't select from, but in fact, in that 4 months period of time, patients would have recurred, right? So they couldn't have gone on the DFMO trial. And it doesn't take a lot of patients recurring and not going on the DFMO trial to really change the probability that the rest of the patients would never go on to recurrence. Okay, so say that this patient never went on. Just one patient, already the COG event-free survival is 86% because you're not including that patient anymore. Say a couple of more patients go off, and so on. So you can see that it does not take a lot of patients before you have the exact same number. And that is really the problem. And I know as parents it must be so hard to say, why can't you believe this? And why do you insist that you have to do randomized trials? And it's because we feel so strongly that if we're going to recommend something, we want to be able to tell you that we've done the best that we possibly can to say that this is the right treatment for your child. And then I didn't even go into if you try to match for other factors, if there was different eligibility, you get my point. So the number of events in the first 4 months is significant. That's a huge risk period. So you can't really match historically with that group because those patients would never have enrolled on the DFMO single agent trial. And they are included in the COG, so you cannot compare the two things. So if you really were to have the same population, there's a very high probability that there would be the exact same results. Does that make sense? So what I say and what I say to the COG group, even when we get really excited about things, is in the end, we have to do a randomized trial. We have to be smart about how we do those trials. We have to come up with novel designs so we can do them as quickly as possible. And we have to collaborate with our European colleagues and our colleagues around the world so that we're all asking questions that really complement each other. And we're not being competitive. We're trying to learn from each other and move the field forward. Okay, so how much time do I have left, Toby? Am I doing okay? 5 minutes? Okay, oh boy. So here are the early phase clinical trials. So there are a whole bunch of trials being done in North America and in Europe where we're trying to think about how can we bring other new agents into induction, and then a whole bunch of trials thinking about how we can improve immunotherapy. So we just ran a randomized trial for patients with first recurrence or primary refractory neuroblastoma, so the kids who didn't respond to induction or they went through everything and had their first recurrence. And we decided to compare two drugs. One was temsirolimus, which biologically may impact the NMIC pathway in tumor cells. And we combined that with chemotherapy, and we compared that to denatuximab immunotherapy combined with chemotherapy. And it was not intuitive that immunotherapy would be the winner here because by itself, immunotherapy hardly ever has effects on really bulky disease. So this was really a hypothesis only and really needed to be compared against something else. So we did this trial where all the patients got irinotecan and temozolomide and randomized to either have the addition of temsirolimus or the addition of denatuximab plus GM-CSF. And we just presented these at the results at this meeting and also at the ASCO meeting. And what we found was that the response rate when we added temsirolimus was not as good as what we had hoped for. But the response rate when we added denatuximab was much better than we had predicted, with about half of the patients having responses. Now, this is 17 patients, so although we are all very, very excited, we need to make sure we know what we're doing. We need to make sure we haven't somehow selected 17 great patients that somehow responded to this. But we are very enthused about it. This is a patient who had bulky lymph nodes in her neck and got 2 cycles and they went away. And none of us had ever really seen that with immunotherapy. So what we're probably doing is probably affecting the microenvironment around the tumor cells and allowing the dinutuximab to get in, because irinotecan and temozolomide doesn't do that alone, and dinutuximab doesn't do that alone. So we're probably having an interaction between these that we hadn't really anticipated. So what are we doing next? We're reopening this trial, hopefully in the next month, to enroll 50 more children so that we can better understand this mechanism and really start to see what's happening, so we know how to best utilize this and where to utilize it best in treatment. And then we are going to do a pilot study of adding dinutuximab to induction. And you would think that that's a no-brainer, right? Why would we do this, and why would we ever think about doing a randomized trial? I think the real important thing is we don't know if we can add dinutuximab to chemotherapy throughout induction. And what we also don't know is if we use dinutuximab early, does it somehow impact negatively using dinutuximab after transplant? So ultimately, this will need to be asked in a randomized fashion, but we need a little bit more information to make sure we're doing it as safe as possible. And I just said that. And then in Europe, similarly, they have a complex trial to try to answer a few things. One is, what's the best combination? Is irinotecan adding anything but toxicity? What's the best? Should topotecan be used instead of irinotecan as a backbone for new first relapse patients? And then asking whether the addition of bevacizumab, which is an anti-angiogenic agent, will improve the outcome. And their idea is, once they figure out what the best backbone is and then do the bevacizumab, then they can do sequential studies adding new agents into that best backbone. And again, we're working together to try to come up with a similar backbone that we're all going to use for these first relapse studies, so that whatever we're doing in North America, we won't be doing the same thing as Europe, or maybe we can even have a trial that's across the world and putting in new drugs more rapidly so we can assess them. And then these are some of the combinations that we're looking at within the NANT consortium. So new agents here are the Millennium compound, DFMO at much higher doses, because that's what the preclinical studies predict would work, is the high dose DFMO, or an agent of sorafenib. I'm going to go through these all. So I don't have any results of those. These are all just the preclinical rationale for why we would use these agents. And then finally, I think most of this was covered by Holger about how are we going to make immunotherapy better. There are some agents like lenalidomide that may enhance cytokine production by the body without having to give it, like the IL-2 or the GM-CSF. There are vaccine strategies and these immune checkpoint inhibitors. And then the one thing I'll end with is the idea of using cellular therapies. Whoops, I didn't put it in here, I guess. Oh, I apologize. I thought I put it in here. To genetically modify T cells in patients to have them be able to recognize neuroblastoma cells and then give those T cells back to patients so they can target their own tumor cells. This has worked tremendously in leukemia, so these are called the CAR T cells. We have a trial for neuroblastoma. Baylor has a trial for neuroblastoma. In England, there will be a trial for neuroblastoma. Unfortunately, solid tumors are not leukemia, and that whole tumor microenvironment is probably going to be very, very important in having us really figure out how to make those T cells be effective. But there's a lot of different ideas, and several of them were presented here at this meeting. And again, it's just a great collaboration of people thinking about how can we best do this. The CAR T cell trials, I don't know of anyone who is doing a T cell trial in Australia at this point in time. I don't know that. I think right now they're very, very early, and they're very single center because the manufacturing of these T cells is very complex. I think if those trials begin to show some efficacy, then there'll be more of an impetus to try to figure out how do you export that whole process of making the cells and everything. And then finally, I just want to say there was this talk about, should we do whole genome sequencing, and then what do you do with that information? And I think that's really the big question. What do you do with that information? And even if you have a target, do we even have a drug that works for that target? So there's two separate big initiatives, one in Europe and one in North America, where we're trying to do sequencing of pediatric tumors and then match them to a particular drug that may be targeting that. And so within Europe, it's the Precision Cancer Medicine Program, where they'll profile a patient's tumor at relapse and then try to have a bunch of different drugs open in phase 1 or phase 2 studies that will then be able to be used for that child. So that child will then be selected for a particular trial based on that molecular profile. And then the same thing in the United States through the National Cancer Institute. There'll be the MATCH program, where, same idea, we'll try to work with drug companies to have a portfolio of drugs, and if you have a patient that has a target for which that drug has been confirmed to work in, that patient can enroll on that study. And the idea is that we can get more information about side effects of those drugs in pediatrics, but also start to say, is it really a tractable target? Is this, it's our hypothesis that this is important, but it may not be reality, and we need to start looking at that. And once we have those signals, then we can think about how to bring it forward for patients, newly diagnosed patients. And then John mentioned briefly about, getting tumor specimens, but this is actually a big deal. Some interventional radiologists can biopsy those bone lesions, but not every child has a really easy bone lesion to biopsy. And sequencing off of bone marrow is only beginning to be really formalized. So this is a lot of work is going into this area to really be able to know how to best do this. So in conclusion, treatment for high-risk neuroblastoma is complex. It's too toxic. We need to come up with different ways. I think that this meeting that, I just had the honor of attending for the last 3 days is really such an example of how the international community is really trying to work together to come up with better treatments. Early phase clinical trials are ongoing to identify which new agents might be best to bring forward, but as much as possible, we have to do randomized clinical trials so that we really know the right answer to what is the best treatment for children with neuroblastoma. So thank you very much for your attention, and I'm happy to answer any other questions.